Hey there, Peyton.
Yeah,
How y'all
I
doing
wish I
today?
was her age. Bella, stop. Yeah. Ugh, my dogs, when they hear a flea make a noise, then they have to let everybody know.
I hear you there. It's an
So
ongoing battle.
they're
I
like, we
just
know Eric had to onto it. He's in his office, like his boss. He was going to be on here, but his boss now like made him take a call. So he's on a call in his office in there. So Bella hears voices there, and now hears them in here. So
and she wants to talk about it too.
yes,
Can you guys hear me?
Yeah.
yep.
Oh, good. Thank goodness. This freaking thing's working for once. Robert, if I needed to send orders, I just got off the phone with Kelly at Carter. If I needed to send orders to her, can I do those in like a little progress note in Tebra and you could send them that way, or how should I do that?
Let me dig into that as soon as we get off of this call. What kind of orders are you needing to send?
Like a couple creams dressing.
Hey, Matt. Hey,
Okay.
guys.
Guys,
Yeah, let's dig into that when we wrap up here. I'll look into that and give you a shout.
Okay.
How's Matt doing today?
I'm good. You guys?
Good. I've got my son says all my calls are echoes, so he bought me these things you put in your ears. Starts with a B. I don't know what it is.
Buds?
Buds. So is it clear on your end?
We don't want things to be too technical for Eric, so we'll call them
Yeah.
buds.
Is it clear? Is it good on your end?
Yeah, sounds good.
Yeah.
All right, good.
It's much better. Good job, Nick.
Same thing, man.
All right, good, good. Hey, Adam, how you doing?
I'm doing well. Yourselves?
Let's see. I'm waiting on my son to get on, and Brian to get. Oh, Nick's on. Looks like he's
Nick's
on.
in.
There,
He's
there he
muted.
is.
There he is.
Hey, Nick, how are you doing?
Hey, I'm good.
I can't hear you.
Oh, you can't?
There you are. Okay. Is Brian coming on?
Yeah, let me see. I know he just gave me a call. Yeah, he's trying
So,
to join right now.
so everybody, this is my son. He's a mini me. So that's not
For better or
good,
for
probably
worse.
for most of you. So, Nick, I have your little earbuds in. They sound better?
Yeah, it sounded a lot better.
Okay. Well, why don't we get started? Because I know Adam's a busy guy and Brian can, and this is being recorded. So, Nick, you guys can look at it when you come back. So, Adam, take it away. I think you know everybody in the group here.
I think
And
so.
yeah, except for my son Nicholas and Brian, they'll be running the Greenville Spartansburg that we talked about.
Okay. So this is, I think, the same one that we did the last time. Can you guys see my screen?
Yes, I can.
Okay, good. Okay. So a lot of the same material. Just tell me if I need to skim over some stuff.
Okay.
I think Kate and Stacy were on the earlier one. So thanks everybody for joining us. A little bit about us. We're a global company. We're the largest processor of amniotic tissue currently in the world. We also we produce all of our products to the highest standards of any company in the market, and we produce to what's called the GMP standard, which is the Good Manufacturing Standard. And what this is this is pharmaceutical grade. To produce a drug, you have to produce the GMP standard, and internationally, our products are recognized and distributed around the world as drugs because they don't have the HCTP 361 human tissue designation. So we have to produce at a higher standard than our peers, which is why a lot of companies will flippantly use this. But I always kind of use the analogy of it's like having Ferrari design a skateboard. You probably wouldn't want it over engineered or pay that much for it. So why would you actually do it? We have to do it, so we do it. To kind of put our production capacity and scale, where most of our competitors in the US produce somewhere between 20 and 65, 70 donors a day, we produce over 500 a day. So our production capacity, as we've kind of been going through this list, when it comes to producing for like a hospital system, we look at some of these deals where they will utilize 2, 3, 4, 500,000 square centimeters in a year. That's a day or so production for us. A lot of our peers would put them on back order, but for us, we could do it in a couple of days. Within this development and design of what we have, we're not a one-trick pony. We're not a single process-oriented organization. We have multiple processes to process tissue, and at the same point in time, what we've done is we've used this to develop multiple platforms and other products concurrently within our portfolio. Part of this has also led to what's going to be launching here this month is our Amcoplast FD product, which is a freeze-dried version of our current technology that allow for a little bit better handling and hopefully a little bit better tissue integration. But it's another modification of what we've got. So what makes our process key is, this is based off of St. Agnes. And it's, I think, the patron saint of motherhood or something like that. But what it does is it helps us preserve the tissue, the proteins, the growth factors, the innate matrices better than a lot of our peers. There's essentially a more gentle wash, more gentle kind of processing done to this, but also through like lyophilization, the way we air dry the product, the way we desiccate it in other ways. It allows us to keep that matrix open, which helps allow for better cellular infiltration, better growth factor utilization. Within each of these layers of tissue, there's different growth factors, different cytokines, different chemokines, different signals, sometimes referred to as exosomes. And what this allows it to do is, as the tissue itself is being remodeled into the wound, more of it is breaking down further, releasing more of these growth factors into that environment. And that's what basically converts that chronic phase into an acute phase and allows for the wound to start, healing it as it normally would. Some of our advantages with this, it's easy to use. It's a single-use product. It comes dehydrated. We offer a lot of sizes because of our production capacity. We offer everything from a 14 millimeter disc to a 20 by 20 sheet. It's easy to determine orientation, but the orientation isn't key. Traditionally, you'll see a wound bed will resorb or remodel the tissue within about 5 to 7 days. So orientation isn't that key at that point. Where orientation kind of comes into effect is the chorionic layer is a little bit stickier, so it'll adhere to a wound a little bit better than the amnion side will. But we've got a notch, and eventually we're going to migrate over to an embossment within the process. It can be used in compatibility with other therapies, whether it's negative pressure, HBO. The product is terminally sterilized, so it offers 10 to the negative 6 sterility protection. It has a 3-year shelf life on the current packaging. The next lot will have 4-year shelf life on it. And it can be stored in room temperature, doesn't require freezers for shelf storage. Again, we offer, I think, and Matt, correct me if I'm wrong, but I think we offer the widest array of sizes on a continuous level, especially with inventory on hand. So when we have discussions with groups about how much inventory, people often confuse our number of boxes with the number of units. So we traditionally have at least 1,500 units of every size sitting on our shelf to make sure that we don't go on back orders, where most of our competition will basically stock about 100 or 200 of most of these sizes, except for their really high volume. We have enough to handle burn centers. We have enough to handle, major hospital facilities, but also our private office business. This product is exclusively for the private office, which is why we have the Q code for it. But you can see with the size offering, it also allows for better compliance with the physicians and the patients. And these are some of the stuff that they look at when it comes to the audits and the clawbacks is, how much waste did you have of the product? So by offering this many sizes, what you're able to do is basically give the doctor enough capacity and enough options so that as the wound is closing, you can bring that down to a small enough size that the doctor's not wasting a lot of product to cover a patient's wound.
And
So we'll
then
kind of
also
jump into, go ahead.
I can say to concur what Adam said. This is 6 to 8 more graft sizes than any other company. So that's a good line for you guys as you're selling, is not just the utility we're talking about, but the options, the size options. So just wanted to share that.
Yeah. So we, some of the specialties that do this, it's your wound care nurses, your WOCNs are your big users. Podiatry, of course, vascular, dermatology, especially when it comes to Mohs, but we also see a lot of dermatologists in certain markets are starting to treat more wounds. And then, of course, your plastic surgeons. The plastic surgeons tend to treat more of the really large and catastrophic wounds. So the type of wounds that we traditionally see, your acute wound is something that you would see normally within a hospital. This is a post-surgical or a surgical wound. Your chronic ones are your wounds that have stayed open for more than 4 weeks. It's usually caused by some kind of pressure, trauma, lack of nutrients, blood flow, poor hygiene, infection. And what this causes is the wound to stay in a chronically inflamed state. And those components, especially like a bacterial load or lack of nutrition, will definitely retard the healing process and slow that healing rate for that patient. And then in complex, you're usually looking for, these are some of our bigger, more recalcitrant wounds. These are some of the large scale wounds that you see. Traditionally, those get taken kind of more back to the hospital. The most common ones we see these days are the diabetic foot ulcers and the venous stasis ulcers, pressure ulcers, and then Mohs are becoming big. Most of it, or you might see, post-surgical dehiscence or a post-traumatic wound where, again, you have a compromised patient. They usually describe the 4 foot tall, 4 foot wide patient with the blood type of Crisco. And those are the ones that are going to have the worst healing rates. And that's where you kind of need something like this to normalize that wound bed environment, something that'll help stimulate the cellular response and the protein response to help, treat those patients. So what are the main stages of healing? So within the first 24 to 48 hours, you look for that hemostasis. That's essentially the formation of the scab. Then you look for inflammation. Within this, in a normal acute wound, you're looking for pro-inflammation. This is that kind of regeneration of damaged tissue. It's the revascularization of the region. It's the beginning of the macrophage response that helps remove the debris from the wound. But what it's also doing is helping flush the environment and create a cleaner bed for the cells to respond. And then you look for that inflammation to also help with controlling the infection rate. Then you have your cell proliferation stage, which is where you're basically restoring that ECM component, that extracellular matrix. This is your fibroblast phase where you're starting to see the tissue regenerate, as well as neovascularization or that angiogenesis. And then towards the end of that, you start to see reepithelialization of the wound. And then your remodeling phase happens over a period of time as you start to see increased collagen, fibrodectin deposition. You see that wound kind of contract and heal. You see the tensile strength and the elasticity of the wound increase. Then those are basically the main things. When you end up with a chronic wound, essentially it gets stuck in the inflammation phase. And then what happens is the tissue is either kind of macerating or it's laying down excess amounts of tissue in certain environments. You might see a hypertrophic scar or this kind of hyperinflammation. So this is where, depositing a new ECM and delivering those growth factors into the wound kind of helps stimulate that chronic inflammation converting into an acute inflammation, i.e. that drop at day 4, to where you start to lead the proliferation phase, which is the tissue regeneration. So how this is done, essentially, the sac itself is used as, it's by the FDA standard, it's considered a barrier, but it's also a filter membrane. It's an inflammation modulating piece of tissue. It's kind of crazy. In one situation, it converts maternal plasma into amniotic fluid, which stimulates kind of this anti-inflammatory, pro-inflammatory soup, for lack of a better term, within the amniotic sac that helps lead the regeneration of every kind of tissue within the body. And outside of that, on that chorionic phase, which you're looking at, is the ability to affect and normalize and prevent the foreign body response from the mother. So it's really a profound tissue when you look at how much of the overall healing cascade and regenerative cascade this controls within the development of human life. So we collect all of these from full-term healthy C-sections, actually even some vaginal births these days. We did a study about a year and a half ago that showed that the bioburden between the two was almost exactly the same at the quality of the tissue, regardless of how it was sourced, as long as it was sourced within a sterile environment. You had a very clean tissue, and then you basically gamma sterilize it or E-beam sterilize it, which then also normalizes the bioburden rate. So, the big part of this is, within these products, what we're doing is we're looking at this. Let me see if I can. Laser
While
pointer.
Adam's looking at that,
There we go.
while Adam's looking at that, guys, one thing to keep in mind too is the chorionic layer actually contains 80% of the growth factors and the good stuff that's in this. So we could talk technically all day long, but 80% of everything we're talking about is the chorionic layer, and we actually maintain that. There's a lot of other companies. My previous company, we didn't have chorion in our product, and a lot of people were commenting, "Why don't you have chorion? Why don't you have chorion?" Well, it's a very important part of this, and I often talk to them about it, but it was a processing to which we got our tissue. So we're in a good place with the chorionic being offered.
So essentially what you have is this, you have this placental disc. This is what offers this integumental tissue component. Kind of, functions a little bit as as a filter membrane, but for the most part, this is what adheres to the womb itself. Then you have the chorionic layer, which is on the outside, and then you have the amniotic layer inside. And the way to think about this is if you have two balloons, one inside of the other, you need to have something that allows for that release and protection against friction and popping. So what you add into that is a Wharton's jelly type product or hyaluronic acid called the intermediate layer. It's essentially a hydrophilic, semi-viscous layer that protects these two from creating too much friction between them, especially as the baby stretches and kicks and moves and grows. And like Matt said, the chorionic layer contains most of your vascular components, your angiogenic components, your fibroblast regeneration, and then it's 4 times thicker. That's why it carries 4 times the growth factors, but it carries a different array of growth factors, and those growth factors are those are the integral growth factors, especially when you're looking at partial thickness and even some of these exposed bone and tendon cases that you'll see in the hospital. Then when you go in the amnion layer, you're basically looking at skin on skin. So the amniotic layer, the innermost layer that's facing the baby, is essentially epithelium to be matched up against epithelium. So that's what allows the baby to not stick to the amniotic sac, is you basically have skin on skin. Your fingers don't stick together when you close your hands. So what this does is it allows for that different array of growth factors depending on where you place this tissue. But again, within these layers, this layer right here has more of this tactile component to it, and the innermost layer has more of this. It's the epithelial layer, so it's a little bit slipperier, technically. Okay. Then we look at our some of the other components within this is you've got a lot of natural defensins. That's essentially that balance of the cytokines and chemokines. Oftentimes, defensins are known for having natural antimicrobial properties. Again, this is all within that filter function of protecting the baby, protecting the mother. And then you've got that distribution within that ECM of those different collagen components, the proteoglycans, the elastin, fibronectin, laminin. Those are the basic building blocks of every bit of soft tissue within the body. And this also helps regulate scar tissue, which is really kind of profound when you look at some of the cases we've done in the past. We treated a patient years ago with that had a burn. He was an albino patient. They have the highest probability of forming keloids of any skin type, and they've literally covered around the eyes, the nose, the mouth, and the only part of the poor guy that didn't form a keloid was literally where the graft was placed. Everything else was covered in keloids, and he ended up undergoing, multiple surgeries, but it didn't affect his eyes, his nose, or his mouth. And this is due to this kind of growth factor regulatory component, where what you're doing is you're modulating those anti-inflammatory growth factors and those pro-inflammatory growth factors. You're creating just enough tissue to stimulate healing, but not develop hypertrophic scarring. And you're stimulating this kind of regeneration, and you're down-regulating the chronic inflammation, which is the anti-inflammatory components. When we launched this, years ago, I made the mistake of telling a doctor that, we were anti-inflammatory, and he goes, "Great, you prevent healing." So there's a component behind that you're not a steroid. You're doing something above and beyond, and that's where we had to add in that component of, well, you're also pro-inflammatory because you stimulate that neovascularization, that fibroblast production. You're stimulating the deposition of new collagen and new skin tissue. So that's why, as we look at some of these competitive products that, they'll go in and manipulate the layers of the tissue, they'll double something up, they'll take something out. I've always been a big fan of, if it's worked for, 50 billion people over the last lifetime of this planet, it's probably pretty good the way it is. So manipulating it, changing it, you're probably going to start having a different effect. But what we see is as long as you've got these different growth factors intact and innate within the tissue, you get a pretty great healing rate. But within these three layers, you have essentially about a 1.8 to 2 millimeter thick tissue that offers better handling than, say, a double amnion graft, which would be roughly 0.5 millimeters thick. They're a lot harder to handle. None of these have any structural integrity. None of them have any strong tensile strength. You can't go in and suture something like this in place, but it'll adhere to a wound, and you could put a non-adherent over the top of it, and you can get it to stay pretty well. But the whole goal is to make sure that within these, and I always use the same analogy. When I was in the spine industry and Infuse was launched, it would grow ectopic bone, and nobody really kind of comprehended the fact that you're taking a bone morphogenic protein and you're up dosing it to 13,000 times the normal level. You're creating this super physiological dose. So the body has to counterbalance 13,000 times the normal protein response to turn that process off. So when we look at this, and we've seen this in the industry for years, where companies will say, "Oh, I have more of this growth factor, more of that growth factor." The content of the quantity of the growth factor isn't as important as the content of the growth factor. So as long as you have a normal cascade and you're not upregulating something, you have the ability to stimulate the tissue regeneration response just about anywhere within the body. And that's why we see that this is done through essentially this kind of exosomal protein response. And the exosomes, I love talking about these little guys because they're awesome. Your body communicates through signals. And it communicates through a signal called the paracrine signals, where your MSCs are basically communicating with the rest of the cells in your body. They tell it exactly what to do. It's basically the blueprint given to the foreman telling the laborer how to work. But if you don't have the blueprint and you're paying the labor, based upon the number of bathrooms or the number of windows built into a house, you can imagine the amount of chaos with windows and bathrooms that you would have if they were unregulated. So what this does is it offers the blueprint for the healing, and that's what's so great about this. We know that from every single placenta, we've developed a healthy human baby from a healthy mom. So we have happy baby, happy mom. Everybody did great. Everybody's healthy. The response and the signal within the tissue is going to be healthy. What this does is it elicits a healthy response in any wound that we throw this into, and even in your surgical applications, it helps stimulate that healthy regeneration. One of the things that these also help do is they help inhibit the invasion of tumor cells, because you're delivering, healthy TNF alpha growth factors. You're also helping prevent apoptosis by creating a better signal for the cells. You're not eliciting this, kind of chaotic response that causes cells to jump into a heavy defense mechanism. So there's lots of growth factors in this stuff. When I started in Amnion, I think they were, talking about 10 growth factors, 20 growth factors. And then we bought a bigger growth factor array from Ray Biotech and found 100. And then we bought the upgrade from that and found 200. And then we bought the upgrade from that and found 500. And then I think they got to the kilo array, which costs like 4 times as much, and they found 1,000. Well, lo and behold, there's over 10,000 growth factors in here, and they modulate every component of the healing cascade. So this is why, as we were playing this game with everybody else, they would come up with we have the R2 C3PO growth factor. Do you have that in yours? Well, everybody has the same growth factors. The quantity wasn't what mattered. It was that, did you have a naturally occurring amount? If you were, creating too much of something, it tends to have a counterbalance. You think of the most complex algorithm in the history of humankind. Take 100,000 growth factors and try and figure out how they all intertwine within each other. I mean, this is something that it's going to take, if you plug this into an AI engine, it might take it a few years to figure this out. It took what, a decade to get the gene. I mean, this is something significantly more advanced. So these are these growth factors, basically modulate and control everything. It's the signal between the entire environment, and that's what's key. This is why we retain everything in its natural component. We don't use a Dakin solution or any kind of bleach. We don't use anything that strips out the growth factors. We're basically doing what we can from a minimal point of view to protect the tissue and make it safe for transplantation. So a lot of the comorbidities that we tend to see in patients, malnutrition, diabetes, obesity, compromised healing, age is a big one, but also in your vascular patients, you see a lot of these compromised vascular structures. These patients also tend to have, low compliance. There's usually a reason they're in the hospital to begin with, or they've got an open wound that's been there for 28 days. You're typically not, with the tater tot example, a woman that would come in for a bath every quarter if they were lucky. They don't tend to be the most hygienic or the most compliant with your healing, and they also tend to have a lot of cats. It's just a joke. You could smell her from down the hall, and it was like 100-foot hall. I only did that one day.
Hold on a second. Tamara, Stacy, you want to comment on that regarding on the patient you have right now?
I'm gonna say there's got to be a big story there with
I'm
Tamara.
like, did you know?
Go ahead. Tell them a little history here.
We have
I
a
felt like-
patient that has probably, Tamara, 4 cats that run around, and now he's having like a little gnat infestation in his house because of like dirty dishes in the sink and things that sit around where his chair is. And we walked in earlier this week to apply his next graft, and he had maggots crawling between his toes.
And his feet from the chair that he lives in had
under his dressings,
Yeah.
and everywhere.
he had the 2
bless
cat
you.
litter boxes.
And
So
we
he
didn't
did not
put
get
him
a
there.
patch that day.
No,
Right.
you didn't get yeah.
Maggots they want, guys. Maggots do good things, but those aren't the ones.
No, we didn't put him there.
When you open the door and you smell ammonia, you know it's going to be a day.
Yeah.
why when
There's
when
so
the
much
guy
more
goes
too
here, I'll
we
let-
could say.
Hey, Adam, quick question as you go through this, because I was looking into clinical studies and the case studies that are in that backpack. And a lot of times it's talking about patch changes every 5 days in those clinical studies. Is there a rationale why 5 days instead of 7? Because obviously the girls can't treat anything within 7 days. They got to wait 7 days or beyond. But what was the rationale in those clinical case studies of a 5-day change?
It was basically like what we did back in the day at another company, where we found that at 14 days it healed at this rate, at 7 days it healed at that rate. It was just one to see if we could accelerate it even further. But typical US practice again is 7 days.
And that's because CMS guys, they're the guidelines, they're the golden
Yeah.
moose out there.
Yeah, I was just wanting. Thank you
Makes
for the
sense.
clarification.
Yeah, strictly data driven.
Yeah, some of the studies that we did internationally were kind of interesting. As I was reading through one of the RCTs that we did on this product that we're working on getting this thing published, they referred to a scrape on a patient. It was about 600 square centimeters. So it was a literal degloving from a motorcycle accident, but it was construed as a scrape within the clinical write-up in the study. So a lot of the patients that they were treating, if you've ever been in India and China, Asia, Pakistan, there's a lot of motorcycles, rickshaws, not a lot of seatbelts. So a lot of interesting traumatic patients, but they have different terms out there, and it's kind of the rub some dirt in it kind of cultures, which is plentiful. So a couple of statistics. These are some older numbers. I pulled these a few years ago for when I put this presentation together. But the overall cost of the healthcare system, I think, is now twice this number. I think it's like closer to 25, 26 billion a year. We do see that still about 15% of the patients will develop a wound that will require an amputation. 17% of them, of the DFUs, will require amputation due to infection. 33% of the 500 million worldwide patients will develop a DFU. It's interesting seeing how, some of these markets, there's a strong cultural component to it, not just dietary. Cultures that have high sedentary lifestyles or very arid climates tend to have these. That's why we saw so many in the Middle East. India is now a huge population for this. And then, the risks associated with this, you've got osteomyelitis, amputation, high infection rate. And once you end up with a bit of infection or osteomyelitis, you're pretty much on a cascade that's almost unpreventable at this point. And then you see the 5-year mortality rates of these patients. And we all know that once you have an amputation, your mortality rate is basically established at that point. That's the 80 and 7, I think, or something like that, 80 and 5. So everything we try and do in this space is to avoid things progressing to this point and getting these patients healed faster. What we are seeing with our product, and this is why we are doing the RCT, is we're seeing these patients respond very fast to our product. We're seeing wounds heal very quickly. We're seeing wounds basically jump in closure upwards of 50% within a single application. So, we're definitely seeing that effect. And I've been in this space since 2010 or 9, and we've seen that there's a significant healthcare advantage to using these tissues, using these products. There's no side effects. There's no adverse events. The products are tremendously safe and incredibly effective. Hopefully, it continues to grow. So wound care is not elective. If untreated and unmanaged, it results in infection, amputation, sepsis, death. Proper care is key, but also you have to have proper compliance with the patients. So where we see most of these patients going, it's your podiatric offices, it's your clinics, it's your wound care centers, vein clinics. You see some going into the ASCs, your plastic surgery, reconstructive offices, dermatology for your Mohs, and even a lot more of these, vascular facilities. We're seeing more grafts applied. because this is where a lot of your venous patients are going. I should add right here, because it's in big bold, where it says Amco Matrix, we're in the process of rebranding everything to Amcoplast to reduce any confusion with CMS and the local max and the LCDs. So all of this will be rolled out in the next few days. You'll probably actually start receiving batches of Amcoplast inventory in the next couple weeks. So it's one of the fastest brand changes I've ever done in my life. I think we initiated this last Wednesday and we're almost done today. So on the chronic and recalcitrant wound side, podiatry sees the most of this. This is why, as we've kind of explored this into other markets, it's the number one cause. The number one, what did Mike say today? The number two concern of the VA, the number two largest line item, I think, in the VA's budget is DFUs, VLUs, and podiatry expenses, behind suicide. Plastics and reconstruction tend to see really large wounds. These are the ones that tend to go to the hospital. These are your big decubitus ulcers, your pyodermas, your large dehiscence that have converted into kind of a chronic stage. Ortho sees a ton of these. They don't tend to do a lot of wound care, but a lot of them tend to come out of ortho. It tends to mostly be spine procedures and trauma procedures. Again, 4 foot tall, 4 foot wide with a blood type of Crisco. You do not have the option of whether or not you're going to operate on that person. You're going to have to fix that person. That person's going to go sit upstairs on a vac for a couple months. In spinal procedures, it's pretty similar. You have a lot of complex closures. One of my best friends is a plastic surgeon, and I asked him early on, and I was like, "What's the most common thing you do?" And he goes, "Spine surgery." And I just come out of the spine industry, and I was like, "How do you see so much spine surgery?" He goes, "It's amazing how many of these posterior cases dehiss." And that's what built my medics. That's what put my medics on the track, was, chasing down spine procedures and that spine volume. But as we've kind of gone, we've seen that that's migrated into the podiatry space. It's migrated into the vascular clinics. You see a lot of plastic surgery use this in big reconstructive cases. We've used this for flap prep. We've used this for graft prep in patients that are very complex. We tend to see a lot of this in general surgery. Again, a lot of trauma, a lot of burns, a lot of big wounds. And then we've used this routinely for a lot of internal applications, wrapping tendons, wrapping ligaments, doing things to protect a nerve, protect something that you've just created an anastomotic repair on, helping it prevent scar formation down on it. If you've ever had surgery and you had that pop 2-3 weeks post-op, it kind of hurts when you break that scar tissue that's adjacent to what the surgical site was. I had a big abdominal procedure years ago, and it took the wind out of me when I popped that scar. So, one of the things we look at is consistent quality of our product. Again, everything goes through GMP standard. We have all the AATB accreditations. It's very easy to handle. Traditionally, it's about 140 to a couple hundred, I think 300 microns in thickness. It easily adheres to a wound bed. You apply it dry, put a couple drops of saline on it. We have seen it improve healing rates. It does reduce the economic burden. And kind of one of the results of this that was interesting was we had a doctor I worked with years ago that did a study at a university, and they showed that they could save the healthcare system roughly $350,000 per patient by saving the limb. What was profound is in that same kind of discussion, the head of the hospital told them that it costs them $15,000 to keep the foot on. They make $12,000 by taking it off. So if you ever had any questions about our healthcare system and its motivation, there you go. So again, we launched a product with tri-layer. We keep all the intact growth factors, especially the intermediate layer. It's very, very important. One of the reasons that, other companies take that out is, there's no IP protection if you try and patent that which is naturally occurring. So you have to change the tissue. And that was an easy layer to actually remove. So if you let it sit in saline long enough, the layers will separate. So easy application, lots of options to secure it. It will hold a tack. Patient's age is not a factor. We put this in everything from, well, with Tenenhouse's baby, a newborn all the way up into patients well into their 90s. Shelf stable, 3-year, 10 to the -6, terminally sterilized. General wound care, dressings, gauze. You could put pretty much anything. It's a lot of standard prep, standard treatments. You just want to make sure that you put a non-adherent over it, so when you do a dressing change, any residual tissue could be put back on the wound or discarded easier. In the debridement standard practices, it can be used in conjunction with negative pressure. We do recommend that if you're going to do that, you put some slits or some holes in it that allow for the pressure to be pulled through the graft and not to the graft. And then, the always reminder that we have with the guidelines from CMS is, it's after 4 weeks of standard of care, and that you could then use your skin grafts. More the same. There's that. Any questions?
Yeah, Stacy or Tamara, do you have any questions from the clinical work you guys have been doing that you have for Adam or Matt?
Can you go back to that last slide? Sorry. Okay. So you just said, so a venous ulceration with some like drainage that we're trying to keep under control. Apply it, and then like some sort of non-adherent absorptive dressing over it, okay? Or should you use, okay.
Or you could use a negative pressure on it, especially if you have a highly exudated wound.
Uh-huh.
That's what I was going to say. If you have more than 25, or I'd say venture on the 15 cc's, you're going to want to put a negative pressure on there, or you're going to want to it becomes labor intensive where you have to rewrap several times.
Mm-hmm.
But if you put an all-inclusive dressing on, that's probably not the smartest. Because what I've seen in the past is you want to like a soft wrap or something. Now it's easier to get off, and also is actually absorbent, so you get another absorbative layer. Does that make sense? Where you have your ABDs or whatever, and then your just Coban, not Coban, but your other fluffs, and then possible Coban. That's easier to cut off too if you're putting more bandages on there more frequently.
Okay. Okay.
Okay.
Now,
Anything else?
Question though.
Another question. We're on our 4th graft placement with this gentleman, and he's showing progress, but it's pretty slow. And we're working on the exudate that we get, and it's under pretty good control with just putting like some sponge type dressings on his. He has a couple other wounds too. And then of course the environment's an issue also. But at what point, like, should I be seeing so much progress, or as long as I'm seeing minimal progress each time? Like, I don't know at what point I say that his environment, and like he's a smoker, he uses the nicotine pouches, he's got the good venous and arterial studies done, and they're good. But I just didn't know how long, what I should be looking for.
Is this the big wound with the guy on the lower extremities? That was a big mess.
That he's had for a while.
Yes.
Yeah, that's it's going to probably take 4 or 5 applications to start noticing something. Hopefully, you've started to see the color of the bed change. It's probably becoming less red and more pink.
Right.
You're starting to see that whatever's in there that's causing that chronic component is starting to convert. But I mean, I think his wound had been open for years.
Yeah.
It will take a little while to jumpstart these.
Yeah, you're talking a lot of time to revitalize the tissue too, guys. Not just the healing part, but you're changing the whole dynamics of this tissue. Not to mention the fact that he is still a smoker and nicotine, so he's not helping himself out, and that's your drawback too. That's what really stinks. But as a medical provider, Obviously, we can't counsel, but what I would say to that is you use your best judgment. But if he's making the rule of thumb I've always stated to my docs, and this is coming from a long history of doctors educating me, is 1 to 3 square centimeters per week in totality. If that's the difference you're seeing, but at least 1 square centimeter, that's what CMS wants to see.
Yeah, and I
Pardon me.
think we went from,
We're
I was going to
seeing
say,
a good bit more than that.
Yeah, we're doing good.
So
Then
we
you're
are
doing,
getting
you're well
some
within
good-
you're well within the guidelines of CMS, if that's
Okay,
part of your concern.
yeah.
yeah, I
Okay.
think
Yeah.
what are you down to, 72 centimeters squared, Stacy? Or and it's going to probably shrink a little bit more after this next one? Because I think you
Yeah.
could have got away with going by down another size, but that would have been pushing it.
Mm-hmm.
Yeah, we started at 100 centimeters, right?
Yeah.
Yes.
Yeah.
Yes.
Yeah.
Where
So
are
we're
we at with
making
it now, Stacy?
progress. I just didn't know if we should be seeing more drastic progress than we are, or if this was good. And it sounds like
Yeah.
we're fine.
You are with the patient this chronic, with this much tenure with this wound. Yeah, don't expect overnight, that's for sure. But it is, I think it's a great question. I think it's something that always has to be on your mind. But if
Mhm.
you have that grace of 1 to 3 square centimeters, that's CMS's blessing. They're seeing the progress. And again, if you look at the history, and again, this goes back to good charting, good notes. This guy's been years with this wounds. You've already sold the story to CMS, in my opinion.
Okay.
I would agree.
Okay. All right.
Tamara, any questions on your end?
I think if there's anything else. He's our challenge for sure.
Yeah.
We're
just-
just running a lot on this gentleman.
Yeah.
How are
But
your,
we are
how are
seeing
you, how are the other, do you have any other patients you're seeing right now, or any opportunities, would say?
We have a couple at the continuous care center, hopefully, that we'll get our hands on soon. Some sacral ulceration, pressure ulcerations. And then we have another new one that's like a diabetic foot ulceration. What kind of insurance does she have? We were wondering if maybe we would have to do some prior auths and things with her.
I think it's Humana, and it's a Medicare Advantage plan with Humana. So yes.
Yeah, you will.
I know, for sure, guys. And a
So I'm
little
gonna have to
trick
just
here,
try-
guys, on the authorizations, what we're seeing, or what
Mhm.
I saw in my previous life in these authorizations, it's detail, every detail you can get from these prior auths, including the rep you talk to, time, date, stamp it, comments, comment period. All these things are going to be critical. And then obviously an authorization number. So with that authorization number, a lot of times they're going to give you a window of treatment. It's like a duration and possibly even a totality in square centimeters that they're willing to approve. So those are things that you'll want to take note of, and you want to definitely put those in your notes, Stacy and Peyton. So
And Humana in particular, they're gonna ask you what you think the window of treatment is gonna be and make a decision off of that. So, Matt, do you think it would be good to maybe give them a wider range to pad it? Or are they going to come back with a lower number based off of that?
it's a great question, and I've seen it both ways. I've seen them come back, and I've seen them be okay with whatever the suggestion is.
Okay.
But I would say, yeah, to pad it, be as forthright as you can with your guesstimation. It's tough with a guy like this, though. If you're using this patient as an example, he's been in this state for such a long period of time. And if they look at the charting, the records, they're going to see that. So they're going to see, and they're going to know that patients like this don't heal overnight. So oftentimes I think you're going to get a little, I don't know if I want to call it grace, maybe a little more latitude, but give your best guess as a clinician. I don't know if padding it would do it. I've had a couple doctors try to do that, but then they do. At that point, they will come back and say, "We think it's more Let's start here," and then come back and we'll reevaluate. That's what I've seen.
Yeah, and I guess you would want to be careful not to over pad it, right? Because then you're just a red flag at that point.
There you go. You could be potentially correct.
And do Medicare Advantage plans, obviously they follow Medicare's LCD's guiding principles, correct? But they put their utilization management criteria, but typically they follow the guidelines within the LCD for the most part. Is that correct?
For the most part, yeah. But again, you're going to get the variances. You're going to get some clinical directors that are, they'll follow CMS, but they have the rule of thumb that's underneath their actual, their Advantage plan, whomever they're working for.
Gotcha. Okay.
Yeah, agreed. No, it was a good question, Eric.
And I've seen some of them too that they do follow the LCDs, but I've seen what was it? It was with Humana. They covered 3 particular patches that I bounced the Q codes off of them for, but then there was the one that we were trying to use was the one with them that just wasn't covered. So that they can go product by product as well.
They can, absolutely.
Well, this
All
was
right,
very
well,
helpful.
Yeah. And
Yeah.
listen, just to the rest of the team here, I wanted to introduce Brian Norton. He's my son's partner in the Greenville Spartansburg area. That's going to bloom for us down there. So welcome, guys. You're our youngsters. I'm the oldster on the group. You're the youngsters.
I see Brian
Yeah,
already
Rick,
blooming
you're not too
the
old.
beard
Great to
too.
meet you
So
all. Yeah.
Yeah.
So Adam, we appreciate your time. Matt, Matt and Adam, if you have 5 minutes after the call, if I can speak to you guys, I'll call you direct.
Sure.
If that's possible. Okay.
Thank you all. Take care.
Hey, Adam,
Thank
we,
you.
we appreciate
Thanks,
it, guys.
Yeah.
Thanks.
Thank you.
Thank you.
Have a good one.
all the
Thank
best,
you.
guys.
Bye,
Bye,
everyone.
everybody.
Bye now.
Bye.